the Viva. Can I have the first candidate?
Yes, Dr. Nuran, you are going to go first.
Yes, I'm here. I'm ready.
Thank you.
Okay, so let's start.
Hello,
How much time we have for the one candidate?
I would put the timer at 12 minutes. So at 12th minute, whatever the case is there, it should be the last.
Sure.
Is that fair enough?
Yeah, that's fine.
Okay.
Good evening and Ramadan Kareem for everyone.
A good evening,
Thank you
Ramadan
so
Kareem
much.
to you as well.
Thank you. Well,
Okay, Dr. Nuran, can you see the screen?
yes, I can see
Yeah.
the screen. Well,
Okay.
this is a frontal chest X-ray of a babygram. It is a frontal and chest, revealing the chest and abdomen of a newborn baby. I see the tubes. I should, well, the nasogastric tube, I think it is a little bit downward than the carina because it should be in patients, in the baby patients, at least 2.5 centimeter above the carina because the trachea is shorter than in adults. And I think it is deviated to the right bronchus. On the other hand, I can see another tube extending from downward upwards to the superior vena cava, which is, I think, even it is a little bit higher. This is a venous catheter. And the arterial catheter, I think, well, it's okay, but the venous catheter is a little bit high and the endotracheal tube is a little bit low. So it could be it could be repositioned again. So I should call the...
Can you please tell me some basic positions of the umbilical arterial catheter?
Yeah, umbilical catheter should be between the superior vena cava and right atrium. So I think
the arterial catheter.
Well, I thought it is in the superior vena cava, in the junction between the superior vena cava and right atrium. If I'm wrong. Oh no, sorry. It is. It should be at T12.
Okay.
Yeah, maybe I'm wrong. I'm confused here. But this is, I think it is up, and the endotracheal tube also.
Okay. What else other than the lines?
The other lines is the curved one is the arterial catheter, and I see the other line, which is from the right side, extending from the right axilla to the middle.
Fine, Dr. Noran. Would you like to comment any other thing or other than the lines on the radiograph?
Well, there is the gastric shadow looks, it's filled with the gas, but there is no bubble, double bubble or no. I'm just looking to the gas distribution in the bowel. I haven't seen any free gas in the bowel, and the lung fields look normal, no free gas, no free fluid in the pleura, and no pleural effusion.
Why would the baby with normal lung fields would have the endotracheal tube? You think the lung fields are okay?
No, yeah, you are right. There is a hazy reticular opacification in both hemithorax. So I think this patient has respiratory, maybe he's immature, and this patient is immature and he has surfactant deficiency, and he has a respiratory distress. There is no effusion. So I think he has either wet chest or respiratory distress syndrome.
Okay.
Okay.
Wait a minute. The same child have the neonatal ultrasound. Can you see the screen?
Yeah, I can see the screen. Well, this is coronal ultrasound of the cranium. I can see there is increased
I have given you the control if you want to move ahead. Like, okay.
Okay, I can see here some increased echogenicity in the right caudothalamic groove. It could be due to hemorrhage. And this is hemorrhage, intracranial hemorrhage. And yes, it is more obvious on the left side, left caudothalamic groove. So this patient has intracranial intraventricular hemorrhage.
Can you tell me any specific name for this in this age group?
Maybe due to vitamin K deficiency in this age group, premature patients. And
okay, can you tell me anything about its grading you know about?
Yeah, I think this is a grade between 2 and 3 because the echogenicity is extending to the caudothalamic groove. So I think this is a grade 3.
And what is grade 4? Can you tell me more about that? When we say grade 4?
Yeah, when there is a periventricular also hemorrhage and dilatation in the ventricles, as I remember. Yeah.
Okay.
Yeah.
Can you see?
Yes, I can see. This is a frontal chest X-ray of an adult patient. There is diffuse distributed, rounded, hyperdense shadows in both lung fields, also in the surrounding soft tissues. So I think as to look to the edge of the films, there is many soft tissue nodules. It keeps me to think of neurofibromatosis, first of all, because of these soft tissue appearances. And I'm looking to the lungs. There is a lot of soft tissue. Maybe it's due to the there's a lot of nodules. Maybe it's due to the soft tissue nodules. I'm not sure if it is projected over the lung fields. The heart looks normal. There is no pleural effusion. There is no any pneumothorax or. You
said neurofibromatosis. What type do you think it is?
I think, soft tissue nodules, most probably due to type 1, neurofibromatosis type 1.
How many types are there?
There are 2 types. This one, there is café au lait, and these are café au lait nodules, and there may be also skeletal skeletal malformations and optic glioma. However, in the second type.
And what about the NF2? What are the hallmarks for that?
Yeah, NF2, there will be more CNS problems like multiple meningioma, bilateral acoustic neuroma, and ependymoma. So it will be more.
And what about the inheritance pattern?
Inheritance pattern is autosomal dominant. In NF1 is 17 chromosomes, number 17, and in neurofibromatosis 2, it will be 22, as I remember. Chromosome.
And can you tell me anything about the life expectancy?
Well, yes, the life expectancy, it depends on the affectants. So we need to survey the whole family because the life expectancy is a little bit low because of these brain tumors, and they most probably go to seeding through the spinal canal also.
Okay. Well, let's go to the next case.
Yeah, this is axial CT of showing the posterior fossa, and I have seen there is a well-defined rounded lesion at the fourth ventricle. Yeah, there is also linear gyral hyperdensities. It could be kept with calcifications.
You have the control, I think, so you can move the images yourself if you can.
Well, I don't know how to move that.
Okay.
Yeah, can you please?
Yeah.
Well, I've seen some gyral increased densities in the right side, in the right occiput and the right vertex. It keeps with calcifications and, yes, let me see, there are gyral calcifications. So, there is no this is unenhanced CT, as I noticed. So these are calcified gyri. It kept me to think of phacomatosis, Sturge-Weber syndrome, and I will ask if the patient has any navy or in the face, or if he has any trigeminal angiomatosis.
Can you tell me any specific associations with that?
Yeah, in Sturge-Weber there will be gyral calcifications, and there will be fifth nerve trigeminal angiomas, and sometimes it could cause cortical thickening and hemicerebral atrophy.
What is the name for that?
Well, the name for that is the Davidov syndrome.
Okay.
Yeah. Mm-hmm.
So you have the control. You don't have to change the sequence. Just scroll this one and tell me about your findings.
Mm-hmm. Well, these are selected axial images. Just let me see, how can I move it? I can't.
You have the control with you, no?
I take the control.
You can see this bar. You can scroll it with the mouse like this.
Yeah.
Yeah. Scroll it.
Yeah. Well, there is selected images, axial images here. I can see there is a, let me see if this is a cystic lesion here. Well, there is rounded cystic lesions with the fluid levels in the pelvis. I can see two cysts. I will.
No, don't change the sequence. I said.
Okay. Sorry.
Just go with it.
Yeah. Okay. I was just if it is gestational sac or if it is a cyst in the abdomen. This is a cyst, and this looks like a gestational sac because I'm not sure of this shadow in it, the appearance. So there is a fluid level in these. If it is not gestational sac, I will think of an ovarian cyst, endometriosis, and can you give me some history about the patient?
Patient is 7 weeks pregnant and she's come with abdominal pain. Okay.
So I think this is gestational sac, but behind it there is another cyst. Yeah, there is a cystic lesion in the right adnexial lesion. And yes, while the gestational sac, I think it is ectopic pregnancy. I think it is outside the uterus.
Any sequence you want to ask for?
Well, if it, can I see T1 weighted images, please?
Dr. Kamal, sorry to interrupt. You can take your time, but this would be the last case.
Okay.
Sure.
This uterus looks bulky, and while it contains the fetus, but we have another mass in the right adnexia, which looks hyper intense on the T1 weighted images. So it is either fat or blood, and I think it is yes, either fat or blood.
So what you will think it's more, either fat or blood, by seeing the T2 and T1 both?
Well, T2 was hyperintense, and so this is methemoglobin. It is a blood. It is a bloody cystic lesion. Most probably.
How will you confirm that?
If we have fat suppressed sequences, I would like to see if there is fat suppressed.
Let me look for you.
Yes, please.
I should have that.
Well, it is not suppressed, then this is a bloody cyst. Yeah, it contains blood, not a bloody, it is a cystic lesion which contains blood or hemorrhagic cyst, most probably due to endometriosis. Yeah, yeah. Okay. So we should inform the gynecologist because there is a risk of torsion of these cysts, and should be under control till the end of pregnancy.
Okay.
Okay, thank you very much, Dr. Ahmed.
Thank you. So should I give a feedback now?
Yes, please. That would be great.
Yeah. Okay. So Dr. Naran, you did quite well in every case.
Thank you. I'm a little bit excited. Forget everything.
No, it's okay. So this was a case with multiple displaced lines, and you pointed them rightly. The endotracheal
Dr.
tube was
Ahmed,
displaced.
we can't see the X-ray. It's the MRI at the moment.
Okay, sure. Let me change it for you.
Yes, please.
Now everybody can see?
Yes.
Yeah, thank you.
So this was the first radiograph. I had shown the neonatal radiograph. This is a premature child with multiple displaced lines. Dr. Naran pointed very well about the misplaced endotracheal tube. The umbilical venous catheter is also high-lying. And so respiratory distress syndrome or hyaline membrane disease was I was asking about in the lungs, which she like forgetting the name, I think.
Yeah, I forget the name just because of my excitement. Yeah, thank you.
And just listen to the question of the examiner carefully. I pointed out 2 times that the umbilical arterial catheter I am talking about, and you were continuously telling me the position of the umbilical venous catheter. And umbilical arterial catheter positions are of 2 high-lying and low-lying. You should read them out, and the examiner usually asks that in the cases, okay?
Okay, thank you.
And this was a germinal matrix hemorrhage. You should use the word germinal matrix hemorrhage, which you didn't use. And the classification should be on your tips. The grade 1, grade 2, grade 3 is when there is a hydrocephalus, and grade 4 when there is a periventricular extension and changes in the brain parenchyma.
Okay.
Next, you pointed out very rightly the neurofibromatosis. The nodules over the skin are the hallmark for that, and at the catchy point, you picked them rightly. And the questions you answered well.
Thank you.
And the next case was the Sturge-Weber. You picked that right as well. And you tell the associations. It was okay. And next is this. This is a 7-month pregnant lady with a endometriotic cyst having a blood fluid levels. And just to point out that when the examiner asked the diagnosis, you are not allowed to change the sequence in the examination. And you have to tell the basic things on that particular sequence the examiner is showing. And then you have to ask for the next sequence, okay? I want to see the T1 or T1 fat set or anything. Don't let the examiner ask you or bother you to what you see next. When you are complete with the findings in the one sequence, just ask or say it that I want to confirm my findings on the T1 or sagittal or coronal, whatever you want. And if they like to give, they will give you immediately, okay?
Okay, thank you, thank you. I was so excited in the beginning, that's why I forget everything.
No, you did it very well, you did it very well.
Thank you indeed.
Thank you, Dr. Naran, thank you, great hot seat. Dr. Saneed, you'll go next.
Yeah, can you hear me?
Yes, we can hear you.
Thank you.
Just give me 1 moment. Let me open the
Take your time.
Few cases. Yes, beta. Okay, Dr. Saneej, can you see the screen now?
Yeah.
Okay. Start.
Okay. This is the frontal AP radiograph of the hand. So I am looking at the cortical outline of the phalanges, the metacarpals, and I am also looking at the carpometacarpal joints. But I cannot see the joint line clearly. The lazy M pattern is not clearly seen at the carpometacarpal junction. So if this patient had any trauma and having pain at this region, then I will think the possibility of a carpometacarpal joint dislocation. And if there is any lateral view or oblique view available, I will compare with it. So in the lateral view, I can see that the carpometacarpal joints, multiple carpometacarpal joints are dislocated. So this patient needs referral to ortho for further management.
Any next investigation you want to done in this particular case?
This I'll discuss with the ED doctor and we'll refer to the ortho. And if they need a CT, then we'll do a CT to confirm the findings. And there will also be a ligamentous injury, but I think for the management, CT will be better.
What additional information the CT will give?
We can confirm the findings and also see any there are any associated fractures or any other dislocations, and we can confirm. Fine details we can confirm. And there is also
okay.
Okay.
In the second case.
So this is the
thyroid ultrasound.
So these are two static images of thyroid ultrasound, where I can see there is a hypoechoic area measured in the one lobe of the thyroid, which is having some hyperechoic peripheral focal hyperechogenicity, with some areas showing some shadowing also. So it's ill-defined borders. So I'll compare with the patient's clinical history, whether this patient is having any only swelling or pain. And I'll also see the other sequence, other images in the ultrasound.
No other images available.
So this is an enlarged one lobe of the thyroid gland is enlarged, and there is an ill-defined hypoechoic lesion.
Do you know anything about the grading of these lesions?
Yeah, it's a Thyroid's 4 lesion with calcified areas, and size is also larger, and that is it is hypoechoic. So this lesion needs further evaluation with FNA.
And what else?
And what else?
What else if FNA becomes positive, some malignancy? Anything you want to do?
Yeah, if the FNA is positive, then we have to do a staging CT, neck, chest, abdomen, and pelvis, and also refer this to the oncology and for further management.
Okay. So let me give you the control. Can you see the CT?
Yeah.
Yeah.
So I've been given CT scan of neck, contrast enhanced images, where I can see the right lobe of the thyroid is enlarged with there is a hypodense non-enhancing area with some calcifications. So can I control?
Yeah. Sure.
Yeah. Somebody's.
Let them draw. You just focus on your case.
Okay. And I'm looking systematically. Sorry. Yeah. From below upwards, where I can see there is a lesion involving the iliacus muscle, and the bone is also destructed. The inferior, the pubic ramus is also destructed with soft tissue component. And by going above, I'm looking for any lesions in the abdomen. The small bowel loops appear normal in a non-dedicated study. The kidneys are okay. I can also see some sclerotic lesions in the vertebrae, and the adrenals looks fine. The liver is okay, and I'm looking for any nodules in the lungs and mediastinal lymph node, and also any rib lesions or any scapular or lesions. So I can see multiple bone metastasis with soft tissue component involving the pelvis and maybe in the spine also. So in my usual practice, I will see it in the bone window to see whether there are any bone changes, and also look at the lung window to see any lung nodules. And so Looking carefully at the lung window for any pulmonary nodules. Yeah, there are multiple peripheral subpleural nodules that is in the right upper lobe, and also I can see it in the lingula, and also right lower lobe, and also left lower lobe. So there are multiple nodules in the lung. So if there are any previous CT lung available, I will compare with it whether they are already present nodules or new nodules. So in the settings, these are most probably representing any metastasis. So I will see it in the bone window to look for any additional bone lesions.
So how to conclude? What you will
So
conclude the case?
Primary malignancy in the thyroid with metastatic pulmonary nodules and metastatic bone lesions. So this is a stage 4
Patient
lesion.
is 70-year-old lady. What type of the thyroid cancer you think it is?
It can be anaplastic carcinoma in a 70-year-old. So,
Okay.
so I'll discuss with this the referring clinician and arrange for an oncology referral and MDT discussion.
Okay. Can you see?
Yeah.
Yeah.
So these are axial images of brain in soft tissue window. I can see calcification
You can
involving
move, scroll.
There are calcifications involving the bilateral basal ganglia. There is some lag when I'm scrolling here.
Okay.
Both the head of the caudate nucleus, the body of the caudate nucleus, and the tail is calcified, and the lendiform nucleus is also calcified. I can also see some subcortical calcifications in the centrum semiovale and also in the frontal lobe and the parietal lobe. So there is diffuse calcifications involving the brain. So this can be seen in FARS disease, or if there is any endocrine disorders like hyperparathyroidism, it can happen, or other causes will be like any congenital congenital causes. So it can be it can be related to endocrine disorders or congenital disorders. So I'll compare the previous images and
next case.
Okay. So this is a bones. This is a nuclear medicine study. I think it's a. There is an injection given on one hand, and I can see excretion in the kidneys and the urinary bladder, and also there is increased uptake in the pelvis.
So what nuclear study do you think it is?
Actually, I can see both soft tissue and also some bones also. And I think this is maybe I'm not sure. I think it's a bone scan. But
a bone scan. What isotope you use in it?
In bone scan, we use technique. Sorry, technetium.
Okay. And you know how after how many hours you take the images?
There are multiple phases like blood pool phase, then like delayed phase, and also some one more phase is there in between.
Okay, fine. Yeah, so what do you think the findings in it?
There is a photopenic area in the femoral head region on the right side. It's an anterior and posterior radiograph. So on one femur, there is a photopenic area at the femoral head region. And I can see excretion in both kidneys, and there is some increased uptake at the ilia crest also. So I will compare the patient's clinical history and also look at the radiographs for comparison. And I think
Any some basic points you can point out with such a photopenic area? Any wild guess?
Actually, a multiple myeloma is a photopenic area, but if this patient is an elderly with having some bone pain or something,
Solitary
then
photopenic area comes with the multiple myeloma?
usually it will be multiple. Plasmacytoma can be solitary, and otherwise it can be. It depends upon the patient's age.
Patient is
Diagnosis.
65 years old and had history of hip transplant.
Oh,
Hip replacement, sorry.
yeah. Then this will be like um, complication related to the hip replacement.
Okay.
Yeah. So this is the radiograph of the pelvis with the both hips. I can see there is squaring of the iliac blades, and there is pelvic inlet is also abnormally shaped like wine glass shape, and there is also there is abnormality at the femoral head and neck region with shortening of the femoral neck and broadening of the uh, uh, trochanteric area, and I'm also looking at the spine where
Sorry to interrupt. This would be the last case. Thank you.
The spine, the interpedicular distance is not getting narrowed, and so this is a bone dysplasia. Probably, if this patient is a short, then it can be achondroplasia. I look at the other images in the.
And what if the patient is long?
If the patient is long, then it can be epi spondylo.
Okay, fine. Thank you. This question was just to tease you, nothing else.
You can take your time in the feedback, Dr. Ahmed. No hurries, huh?
Fine.
Thanks. These are very good cases. Thank you very much, Ahmed.
You're welcome. So this was a case of achondroplasia, simple as that. Some cases you have to just tell that it is, and they don't have any differential diagnosis. I think so. I could be wrong, but that's my opinion. Fast disease, you were right. This was a simple case with multiple calcifications. You should know, and the differential possibilities of the metabolic disorders, you said so. And this was the case of bone scan, which have a hip transplant, replacement. I'm saying transplant again and again. Hip replacement and the metallic prosthesis, which is used in the replacement, that they cause the photopenic area during the bone scan. So it's normal, okay? It's not abnormal. And what else I have showed you? Yeah, the thyroid case I have showed you, that's fine, but you said the thyroid's category in that as we know technetium 99, and we tag it with the MDP or HDP, which stands for the bisphosphonate something, and you take the images. Usually the triple phase bone scan is something else, but when you take a simple bone scan, so you have take the images just after the 2 hours, the anterior projection and the posterior projections. 2 hours after the injection of the isotope, you take the images. Okay. And that thyroid scan I showed.
Can I ask one question, please?
Yeah, sure.
Is there over uptake in the lower lumbar region in the bone scan? Looks like focal uptakes in the lumbar region in the previous one?
Yeah, this could be degenerative in this case.
Okay, so it is not
sometimes the patchy uptake could be degenerative in the facet joints.
Okay, thank you. Sorry.
It's usually a normal finding you see in the bone scan cases.
Okay, thank you.
Okay, so this was the case in this. This is a moderately suspicious nodule. Use the thyroid's category, but I think so you should use that category M1, U1, U2, U3, U4 category for the RCR. Okay, and rightly so. point out while the explanation that you want to do the lung window, you want to take the bone window. Don't take so much time in this CT scan.
We can't see the CT scan.
Let me share it. Yeah, this was the case. In this, he was right. Just for this, you don't have to explain the thyroid nodule again, and you just said that this confirms the finding of the ultrasound I have explained already. And now for the staging CT, I'm looking for the lymph nodes, I'm looking for the lung nodule. For that, I want the lung window. And now I'm looking for the anything else, and comes down, and you will see this. It was your luck that you just flip to the last image and you get this immediately. But there is not such a case, and you usually you have to follow the complete images to find out the lesion. So this was the case of thyroid carcinoma and anaplastic thyroid carcinoma. You were right that in 70 years of age, anaplastic is though rare, but in adult age it comes above the list. Otherwise, in younger age, you will get the papillary carcinoma and the follicular carcinoma. And for
you are next.
Yes, I'm here.
Just give me a minute. Let me open up some new cases.
Okay,
Sure.
take your time.
Dr. Awad is next.
Okay. So can you see the screen?
Yes.
Yeah. Okay. Start.
I'm seeing a frontal and abdominal radiograph of a skeletally immature patient. I can see there is a nasogastric tube in a proper position. There is a gross bowel dilatation. There is also a streak of air lucency scenes projected over the right hypochondrium. I will magnify to confirm this. Most likely a portal venous air gas. I'm now tracing the distended bowel loops. There is also in the right side the possibility of bubbly air lucency seen within the bowel wall. So I would communicate with the physician regarding the age of the patient. If this is a
Sorry, regarding what?
The age of the patient, is this a preterm? If this is a preterm, this is most likely necrotizing enterocolitis with portal venous gas. I would also confirm searching for any...
Patient is not a preterm.
Not a preterm. So I'm now suspecting still I'm seeing the streak of air lucencies in the right hypochondrium and at the grossly distended bowel loops with intramural air. I would also ask for lateral decubitus view to exclude any free air.
Okay. Anything else you want to point out?
How old is this patient? What is the complaint?
15 days old.
15 days old. So this is a neonatal with the bubble air, with intramural air and pneumatosis and portal venous gas, most likely necrotizing enterocolitis.
Okay. How dangerous the portal venous gas in this age group?
There is a debate or controversy. It is not much means there is bad prognosis. It is almost could be due to the intramural
What controversy usually you see in your usual practice or in your hospital setup?
I think they need the serial chest radiograph and abdominal radiograph for the progression and to exclude the development of perforation.
So you will follow up this patient or you will ask the pediatrician something?
Yes, sure. I will follow up and ask about further history.
Fine.
Okay. This is a frontal chest radiograph of an adult male patient. There are bilateral more or less symmetrical, homogeneous opacity is seen involving both upper lung parenchyma with associated interstitial thickening and reticulonodular infiltrate associated with volume loss on both upper lobes. I can't see any calcified lymph node or hilar opacities, no pleural effusion, no pleural plaque or calcification. The bony thoracic cage looks unremarkable. So I would like to ask about the occupational status of this patient. This could be a case of upper lobe fibrosis with progressive massive fibrosis, could be due to silicosis or pneumoconiosis.
Any other differential for the PMF you want to put in?
Other differential would include those causes of upper lobe fibrosis, such as sarcoidosis and neurofibromatosis or ankylosing spondylitis. But
sorry, what in this particular case, please? But in this particular case, you put the first, second, third differentials. Can you please enumerate?
The cause could be sarcoidosis and occupational cause.
Okay. Okay.
This is a dorsipalmar view of the hand of adult patient. I can see previous amputation of the little finger. And I can see there is multiple calcific rounded foci seen within the soft tissue. Most likely fleboli in hemangiomas. There are multiple also lucent lesions seen involving the proximal phalanx and the second metacarpal with expansion. They have narrow zone of transition. So presumably this patient has a previous operation for multiple enchondroma with soft tissue hemangioma. This most likely Mafushi syndrome.
Okay. So what do you think why the amputation had been done in this case?
This could be previous one of them undergoing malignant transformation because there is a possibility of malignant transformation.
How many chances are there as compared to the normal population?
I think 1/3.
Sorry?
1/3. 30%.
Okay. So let me give you the control. Can I have the spelling of your name?
Dr. Awad Ahmed. Here it's Ahmed.
Ahmed?
Yes.
Ahmed Ibrahim?
No, I will ask for remote. No.
Yeah, please. That would be easy.
I don't remember how to ask remote. Yes, I requested.
Yeah, approved. Okay. So this is MR brain of a young patient.
Okay, I'm presented with an MRI multi-sequence multiplanar of a young patient. Can I scroll? This is axial T2 weighted M, where I can see left frontal hyperintense lesion seen with the internal heterogeneity. It is, I want to confirm whether it is intra-axial or it is seen related to the frontal horn of the left lateral ventricle. Has a dural base It is mostly an extraaxial, but the signal is with internal abnormal signal or linear strands like. Can I see other sequences?
What else on this you can see? Anything else other than
It is being here cystic, hyper intense with the signal pattern similar to the nearby.
Anything other than this cystic lesion you can see in the brain?
I think the subarachnoid spaces. Normal hyper.
And any comment on the ventricles?
The ventricles are dilated, evidenced by dilated temporal horn.
Okay, which sequence you want to see?
T1.
Okay. Scroll it.
So in T1, there is a hyperintensity within the subarachnoid spaces, and there is a fat intensity within the cystic lesion. Also, it is connected to the ventricular system and the frontal horn with the leveling. There is also fat globule outlining the third ventricle. So this most likely a ruptured dermoid cyst with a chemical meningitis. This is an emergency. I would inform the referring physician and refer to neurosurgeon.
Okay, you said that he has meningitis. How you confirm that?
First instance by clinical, if this patient mostly has a severe headache and because of the fat reaching to the ventricular system and the subarachnoid spaces. And also with the contrast study, we'll see the leptomeningeal enhancement.
Okay. Yes. Can you see?
Yes.
Okay.
Can I scroll?
Yeah, sure. Hepatitis C positive.
Okay. I'm presented with a contrast enhanced CT of the abdomen of a patient known with hepatitis C positive, where I can see, I'm now looking from up downwards. This is an arterial face. There is a heterogeneously enhancing mass lesion seen in the right hepatic loop, segment 6, with the arterial hyperenhancement. I can see also the prominent or enlarged feeding arterial supply. The liver contour is smooth, spleen unremarkable. There is also multiple enlarged lymph nodes seen at the porta hepatis celiac axis. I would confirm this also.
Sorry to interrupt, Dr. Kamal.
Yeah.
So I will, with multiple enlarged lymph nodes, I would confirm the arterial enhancement of the lesion in the other face with the washout. So I want to look at the portovenous face.
Okay. Here you have it.
There is appreciable washout of the mass lesion. So giving the history of hepatitis.
You can scroll it.
Yes. So giving the history of hepatitis B virus, hepatitis C virus, this most likely an HCC with multiple lymphadenopathy. I will correlate this with alpha fetoprotein and recommend discussion at MD team and possibility of further intervention radiologic management, including
okay, what if alpha fetoprotein levels comes out to be normal?
if the alpha fetoprotein, because the pattern of enhancement, this is most likely some case of HCC could come with the normal alpha fetoprotein.
Okay, so how much you rely on the AFP levels for the diagnosis of the HCC?
I think, sorry, I don't know exactly.
And what is the diagnostic tool you use for the diagnosis of HCC?
I think the diagnostic tool, the imaging better. Now there is a change to the histopathology, but I think the imaging with two modalities, CT and MRI.
Okay. And in what cases you advise the MRI?
If there is a controversy, if there is a cirrhotic nodule or
How much controversy you have in this case?
regenerative nodule, I think. This is, I think there is clear washout.
So this is HCC.
Yes.
Okay.
This would be the last case, Dr. Dr. Kamal. Sorry.
Fine, we should move to the feedback then.
Yes, please.
Yeah. So in this case, this is a clear-cut you can see the case?
Yes.
Yes.
Yeah, this case was for necrotizing enterocolitis with portal venous gas. And in neonate, the portal venous gas is not showing that much bad prognosis as compared to the adults. That was I asking. And he answered almost correctly. This is the case of Maffucci syndrome, and there is amputation, he pointed out rightly, and there are the multiple hemangiomas with phleboliths, multiple enchondromas, and if the percentage is more as compared to the normal population, it's 10 to 20% more as compared to the normal enchondromas. Just go out for the exact percentage from the books.
Okay.
If anybody can point out the exact percentage. Sabahat?
The chat is blocked. We will read from the books.
Yeah,
okay.
yeah, please read that exactly.
Yes.
Okay, okay. So, and this was the case of the progressive massive fibrosis with the upper lobes. Okay, don't utter the Chapman, don't vomit out the Chapman in the Viva. This is the point which many RCR, our senior teachers, Dr. Sami, and everybody has told us many times. Just tell the diagnosis and the differential diagnosis in that particular case you see. Ankylosing spondylitis, everything, you don't have to put it in the differentials in this case. Okay, so silicosis and sarcoidosis should be the top two differentials in this case.
Okay.
Otherwise, you were very good in everything. This was a case of ruptured dermoid cyst. In this T2E sequence, I am continuously pointing out that tell me about the ventricles. There is a very clear-cut linear line which is separating the fluid, which is depicting that there is some fluid level in the ventricle as well. So you should point out that in the T2 sequence as well. So that was the point I was asking, because on T1 it was very obvious. Anybody can tell this. Okay. And in this case, you were right that it is HCC. The thing you miss is the portal vein thrombosis.
Yes, yes.
Right. This is a very important point whenever you see the HCC, and then you have to classify the thrombus as the bland thrombus or the tumor thrombus, because it has a prognostic factors over the patient management.
Yes.
AFP has no role in the diagnostic criteria of the HCC. It is the imaging modality and CT liver dynamic, which is the answer to the diagnosis. And in ambiguous cases, you can proceed to the MRI, and no role of specific biopsy in straightaway cases. If any atypical, then we go for, if MRI also don't answer, then we go for the biopsy and histopathological diagnosis.
Yes.
Okay.
Okay. So this is a bland thrombus, I think.
Yeah, this is a bland thrombus, but
yes.
You missed it.
I missed it.
Yeah. Okay.
Okay, thanks. Great.
Thank you, Dr. Awad. Thank you, Dr. Kamal. Dr. Wasif would be next.
Okay, so everybody can see the case?
Yes.
Yes.
Okay. So can you please ask for the control for me?
Yeah.
Okay.
Okay.
Fine.
Right.
Limited range of movements.
Okay. So I'm provided with an MRI study of a skeletally mature patient who presented with limited range of shoulder movements. These are the coronal T1 weighted images. Just scanning the images to look at the rotator cuff tendons, and the supraspinatus appears fine. There's no degenerative changes in the acrocavicular joint. The glenoid fossa as well as the signal intensities of the bone appear fine. So there is some degeneration with thinning of the supraspinatus tendon. I'm suspicious if there's tendinopathy or perhaps a partial tear. I would like to see the coronal stir weighted images, if available. Okay. So there is, within the coronal stir images, there is increased signal intensity in the distal aspect of the supraspinatus tendon.
Anything else other than that?
There is no significant joint effusion. There is some degenerative change as well in the acromioclavicular
Focus on the
joint.
supraspinatus.
So there is thinning with increased signal intensity and suggestion of a partial tear, but the tendon itself is not discontinuous. There's high grade tear. There's no atrophy of the supraspinatus muscle itself. So this is in keeping with, yeah. So coming back to the T1, I can see that there is intensely hypointense focus seen within the distal near the insertion of the supraspinatus tendon. This could represent a calcific focus, as it was also hypointense in the STIR and the T2 weighted images. So this could be also a calcific tendinopathy. I would like to correlate this on the X-ray images if the patient has any, and also compare with any available previous images. So on the X-ray, I can see that there is a clear calcific focus near the insertion of the supraspinatus tendon, and this is in keeping with calcific tendinopathy of the supraspinatus tendon. I would inform the findings to the referring physician and ask for ask for management.
Can you
So,
see?
yeah.
Let me open some other sequence for you. Please. Okay.
Okay. So this is an MRI brain study. These are the axial T1 weighted or flare weighted images.
Sorry?
These are the axial T2 flare images.
Okay.
Okay. I can see that there are bilateral subcortical intraaxial hyperintense lesions in the frontal hemispheres. The left one is larger. These lesions are ill-defined, and they are subcortical, and they appear to be involving the U fibers. I'm looking to see if there are any other lesions in the rest of the brain. The rest of the brain parenchyma appears fine. So these are localized to bilateral frontal hemispheres. Depending upon the presentation of the patient, these could
Altered
represent
level of consciousness.
altered level of consciousness. So, is the patient young or old? Okay. So,
Young.
in a young patient with altered level of consciousness, this could represent demyelinatory changes.
What else sequence you want to see?
I would
What
like
are you
to
thinking
see,
of?
Yes, I would like to see the T1 and diffusion weighted as well as and contrast sequences. So we'll start with T1. T1,
Okay.
it appears they appear hypo, and DWI. Can I also see the DWI?
Yeah, sure. This is DWI.
Yes. So on the DWI weighted images, there's a rim of restriction or DWI hyperintensity, which if low on ADC would denote diffusion restriction. And is there also
Can you scroll
post-contrast?
T1 for me as well?
Okay.
And look a bit carefully. Anything else you want to see?
So the post-contrast would be helpful. They appear to be high. There's a slight hyperintensity on T1, so GRE would probably be useful over here to see if there is any blooming.
What are you thinking? You haven't tell me any differential or any
True. So
definite thing.
I'm thinking in between demyelination versus metastatic lesion.
And
Or
pardon, which demyelination comes with such T1 hyperintensity?
right. So I would not think of demyelination here. I would think of metastasis versus hemorrhagic infarct. But DWI,
So I
there
have
was
the GRE for you. This is the GRE.
right. So on the GRE images, there's intense blooming, denoting hemorrhage. So in a young patient, this could be secondary to malignant melanoma metastasis, or it could be due to lung or sorry, that would be in an elderly patient, but still lung and renal cell cancer metastasis could be kept in a.
But other than the metastasis, you will think of with
So
sudden
I would also
history.
think, yeah, I would also think of hemorrhagic infarction as in dural sinus venous thrombosis. So I would look to MRV sequences to see if there's any thrombosis.
Okay, so can you come back to T1 and tell me, are there any signs of dural sinus thrombosis on this or not?
Yes, okay. So there is high signal intensity within the superior sagittal sinus. And also some of the superficial cerebral cortical veins are appearing hyperintense. So this could most likely be a case of thrombosis. And this is the MRV, which confirms a large filling defect within the superior sagittal sinus. And extending into, extending into the right side, the entire venous system, probably.
Okay.
Yeah.
So what will you do next?
So I would urgently inform the referring physician and the stroke team. This patient would need to be put on anticoagulant therapy at the first instance.
Okay. So this is your next case.
Okay. So I'm provided with an MRI study of the brain.
Young child had history of retinoblastoma.
Okay. Of a young child with history of retinoblastoma. These are the T2 FLAIR images. I'm just scrolling through the images. I cannot, on my first pass, I was not able to see any striking abnormality. So I can see that the left eye globe is smaller than the right, as well as the left optic nerve is shortened. These are likely either post-surgical changes or post-radiotherapy changes. I'm looking to see if, sorry, if I can just, I'm looking to see if there are any more focal lesions that I can elucidate on these images, but I can only see mild ventriculomegaly with a symmetrical.
Okay.
And there is also prominence of the choroid plexus, again symmetrical.
What else you want to see?
I would like to see a T2 and T1 and post-contrast images. So on the T2 weighted images, there are no obvious focal lesions. There is again mild hydrocephaly. I would like to evaluate those intraventricular lesions on post-contrast if available.
This is the post-contrast.
There's no significant enhancement of any intraventricular lesions. There is diffuse leptomeningeal enhancement bilaterally, more seen along the inferior aspects of the brain. However, I cannot see any focal masses. So in a child with previous history of retinoblastoma, this could perhaps represent metastatic seeding of the meninges. The other differential in a post-treatment patient could be TB meningitis, as if this patient is having history of chemotherapy and low immune status. It could be an infective etiology. So I would inform my findings to the referring physician, ask for the clinical status of the patient, if the patient is having fever or any raised inflammatory markers.
Yes, patient is having fever and patient is unconscious. What else you want to communicate to the clinicians?
So in this
They
case,
were very much concerned about the prognosis.
Infectious meningitis should be the first possibility or clinical diagnosis in this case. And a chest X-ray should perhaps be performed to see if there's any focus in the lungs. Cerebrospinal fluid tapping can be done to see if there are any infective markers seen. So there is.
Okay, this is diffusion. Any comments on this?
On the diffusion weighted images, there is restriction along the cerebral gyri, the cortical margins. So this could indicate abscess or infective or edematous changes within the brain itself. So this does
Can
not
you point out the abscess, please?
No, there's no abscess. There's sorry, I didn't mean to say abscess. I mean cytotoxic edema within the brain, or early ischemic changes.
Okay.
So this could be of concern regarding bad prognosis for the patient.
Dr. Kamal, we should go now to the feedback because the time is up. Thank you.
Okay. So, Dr. Wasif?
Yeah.
Yeah, you did good. Sorry, the cases were tough on you. Pardon for that.
I was thinking why I didn't go first.
Dr. Kamal has changed, you know.
So the cases that you point out it right later on that it is a calcific tendinitis of the supraspinatus. So when on this there is also it is also evident over here, but on the T1 far side you demand for it is very evident on that image.
Yes.
Okay. So whenever I am saying that focus on the supraspinatus, anything else, the examiner is not interested and not liking the response you are giving. So look for something else and try to tell anything else about that. So pointed out right, you ask for the radiograph, thank God in the end. So always whenever you are responding the MSK MRI in the FRCR or anywhere else in the examinations or in the life always correlate the findings with the radiographs. It's a very important point. Okay.
Okay.
The next case was DST. It was DST. These were the hemorrhagic infarcts. And when you ask for the T1 and that, it was very I think so. There is a hallmark for that. And when I said, given you the history of the sudden altered level of consciousness, so think for something relative acute as compared to the metastasis and SOLs and neoplastic etiology, everything you were pointing out.
I've
And
not
these
seen
are very
bilateral infarcts related to, I mean,
these
feel
were
my
bilateral.
exposure
These
is
were bilateral,
yeah, but
larger on the left side, but this is also on the right side.
Yeah.
And the bilateral hemorrhagic infarctions in the superior parietal lobes are very much specific for the DST. Okay, they are.
Okay.
And on this, when you ask for the GRE, I stopped at this image as well. That made you point out that GRE is very specific for the thrombus in the veins, and this is hypointense signal is very much specific for the thrombosis. GRE is the very much specific for thrombosis. So I stopped at this image 2 times, but you didn't respond on that. So this was a DST. And the next case, okay. So this was a meningitis. This was a meningitis, but on the flare you said you cannot see any hallmark, any definite abnormality, but the hyperintensities in the bilateral cerebellar hemispheres and faint hyperintensities over the cerebellar sulci. Cerebellar sulci was evident. On T2 it was also there. On this sequence, but on the post contrast you pointed it out right, that this is the this is the meningitis. So the source was patient was operated for the retinoblastoma. There is a little bit defect in the superior wall, and it was the infected meningitis with global ischemia going over. Okay.
Okay, thank you.
Any questions of anybody? So don't say abscess. You've said the word abscess. Okay. With this abscess. Okay. Let me see. May I have any more cases or not?
After the last session, I would pray that you are you have finished your case. No. Go ahead. Yeah. I'm next, Dr. Kumar. I'm next. I'm with you.
Okay. Okay. 76-year-old lady with vague abdominal pain.
Okay. Should I ask for the mouse control?
Yeah, please ask for me.
Okay. Yeah. So this is the axial CT images of
focus on the abdomen and pelvis. Okay, sorry for that interrupting.
No problem.
Focus on abdomen and pelvis.
Okay. So CT of chest, abdomen, and pelvis in a 70-year-old patient who presented with abdominal pain. As instructed, I'm going quickly to the level of the abdomen. So this is CT abdomen, portovenous phase. I'm going to have a quick scroll first before commenting. The presenting history is abdominal pain. Okay, so I'm scrolling down craniocaudally. Apologies, I have a sort of lag. Okay, so now I'm scrolling back up. There's a bit of lag on my side. So as I'm scrolling up, I'm coming to the level, the kidneys are grossly unremarkable, but I'm coming to the level of the pancreas. And at the level of the pancreas, I feel there's an abnormality. I'm going to scroll a bit slowly. There is something abnormal with the This is
Okay,
the splenic.
it's okay. It's normal.
Okay,
Ignore
the
it.
pancreas is normal. Okay.
Yeah.
So I had a quick look at the kidneys and I did not see any abnormality. I'm looking at simultaneously at the venous system as well.
Look for the bowel pathology.
Okay, so struggling with it. I'm coming down again. So coming, there is a calcified focus in the region of the mesentery. I'm coming down. I do not see any surrounding retraction of the mesentery. The ascending colon seems to be a bit abnormal. There is a small defect in the anterior abdominal wall, and I believe there is a bowel loop herniating into the through the umbilicus defect. However, no proximal bowel abnormal dilatation noted. There is stranding in the right iliac fossa as well. Apologies for going so haphazard. So summarizing, I have seen a small umbilical hernia with a bowel loop. However, no signs of bowel obstruction noted. I saw an abnormality in the region of ascending colon, the right-sided colon, with fat stranding in the region of the right iliac fossa. I'm trying to locate the appendix, and I'm also concentrating on the ascending colon. So I believe that this is primarily a colon-related pathology. I would also like to see the coronal views, because at the moment I'm thinking in lines of inflammatory bowel disease. And I would like to see if there is further involvement of the bowel loops. So
I don't have the coronal. Can you please answer over these images only?
Okay. So primarily this is a bowel-related pathology with fat stranding around the ascending colon. There are few perhaps sub-centimeter lymph nodes and a calcified lymph node in the mesentery.
So what do you think? Either it's acute something or something chronic, and you don't want to raise some alarm, or not?
I would think in lines of inflammatory versus infective. I do not see any signs of perforation. I do not see any free fluid or abscess, but this patient does need further workup.
The patient had done the ultrasound and there was probe tenderness in the right iliac fossa. They are suspecting the appendicitis in this case.
Okay, I retract my previous statement. I think there is a blind ending tubular structure, which is hyperenhancing. So I would give the suspicion of appendicitis with right-sided right iliac fossa fat stranding and inform the surgeons for management.
Okay. So let me go for the next case. Okay. Can you see?
Yes, I can.
Okay.
So these are contrast enhanced CT abdomen, which is demonstrating multiple focal lesions in the liver. This is portovenous phase. I can also see multiple lesions in the spleen. And I do know that this is a portovenous phase. I can see the portal vein as well. So this is multiple hepatosplenic focal lesions. There are multiple.
Okay, what sort of the lesions you see in the spleen?
In the spleen, actually, I'm seeing a sort of, linear trigoid sort of pattern. That is why I was concentrating whether this is arterial or venous phase, because in arterial phase, the pattern of the spleen is sort of trigoid. It is not.
So it's a mistake on the technician side. They took the portovenous phase a little bit early, so it's a mixed phase.
Okay. So I would disregard the splenic lesions. So this is basically pan-segmental hepatic lesions. I'm concentrating on the pancreas as well. I believe the pancreas is replaced by, actually the whole pancreas seems to be hypo-enhancing with discrete tiny focal lesions. Okay, now the splenic vein itself, although it is arterial phase, as you told me, but I do not see any thrombus within the visualized veins. I'm going down and I see multiple. I do not see any other significant lymphadenopathy. The patient seems to be emaciated. There is fluid in the pelvis as well. And this does not, I'm trying to see the uterus to
ignore that, just focus over the abdomen. Yeah.
Okay, so there is fluid in the pelvis. There is the pancreas and the liver is abnormal. I'm thinking with the multiplicity of the lesion in the pancreas and the liver, I'm wondering if this is a case of tuberculosis, of disseminated tuberculosis with lesion in the pancreas and the liver. I'm also trying to look, I'm concentrating again on the splenic vein. Actually, splenic vein is not visualized. It's thrombosed, if I may.
Yeah, 1 minute, 1 minute, please.
Yes.
Yeah, just focus over this image.
Okay. So this is the portal vein. It should commence here, and the whole pancreas is hypodense. The splenic vein is not visualized. So either it's infective or it's a primary pancreatic neoplastic lesion with hepatic metastases. If this patient is elderly,
33-year-old male, female.
33-year-old female. So in that case, I would be thinking in lines of mucinous pancreatic cystic lesion with malignant transformation, which has led to the hepatic metastases. If there is any previous CT, I would like to compare with it. Otherwise, this patient would be referred to GI with hepatobiliary MDT for further management.
And what about the tuberculosis thing you were saying about?
Yes, tuberculosis is also in my differential. For that, I can ask for the chest X-ray. I can ask for the history of contacts. A biopsy of the hepatic lesion can also help in the histopathological diagnosis. And in case if it turns out to be a TB, then there would be isolation of the patient and screening of the
What thing
contact.
you will take on the first line? What differential you will put on the first line? The tumor or the TB? These are two very differential, very wide differential you are giving to.
Yes, you are right. The first differential I would put as, because this is a young patient, I would put TB in my first differential, and the next would be the neoplastic lesion of the pancreas.
Okay, okay. So these two cases only I have the more. Just to start with the feedback with this one.
Yes.
So this was a case of pancreatic carcinoma with hepatic metastasis.
Okay.
Okay, splenic vein is completely occluded, and on this image, the splenic artery is actually also very much thread-like only, and there were multiple collaterals you can see over this perisplenic, peripancreatic, and lienorenal region.
Yes.
The whole of the pancreas, yes, it is replaced with multiple heterogeneous lesions, and this is the focal dilated pancreatic duct we can only appreciate within the body segment, which is also dilated. Rest of the pancreatic duct is not well visualized. The liver lesions, they have a bit target appearance, if you can say, heterogeneous enhancement with central, and this is very much specific for the metastatic appearance. Okay. And with this pancreas, I don't think so that TB would come in the differential, because there is no other significant necrotic lymphadenopathy, anything. Yes. And if you also you have this, they can, but if you ask for the lung window, there are multiple nodules in the lungs as well, which you haven't asked for. So
True.
they were the metastatic nodules in the lungs. Okay.
Yes, yes.
So this was the metastatic adenocarcinoma of the pancreas. So always complete your checklist and don't give that much wide differential like malignancy and TB.
Yeah.
Although TB can present like anything, but still we have no thickening of the peritoneum, we have no free fluid so much, we have no significant lymphadenopathy. These all things are negating that it would be TB.
Yes.
And the next case I showed you was the 76-year-old female. Yeah. So this was the case of the acute appendicitis. In this, the cecum and the ascending colon were inflamed. There was trending. You can see the screen, no?
Yes, I can.
Okay. There was trending changes, and this is the appendix.
Yes, it is.
Okay. It is the appendix because it is blind ending on this side, and on the other
True.
side, it is communicating with the cecum, and this is the ileum, which is coming from the other side. So usually what I have observed, they don't give you coronal or sagittal in the Viva because they don't have so much time to give you the reformats. Although
True.
it's fine to ask for that, as I have also asked for in 1 or 2 cases, but they didn't show, and they said me that tell us on this provided images.
True.
So this was the case of acute appendicitis, and in the other second thing was in this case was the endometrium was thickened for the 76-year-old female, which
Yes.
also needs some clinical follow-ups. Okay.
Okay, Dr. Kamal.
These
I'm stopping the recording.